So what is an eicosinoid? It's a funny name. It's carbon fatty acid. So what eicosinoids are involved on, we've looked at different hormonal responses. So we've looked at some paracrine responses like we saw in the intestine and this gastric lining, which is localized hormone responses. We looked at big general hormone responses talking about systemic hormones, insulin and glucagon. And now we're going to talk about a very, very, very short acting. They only last sometimes on the order of seconds, but very short acting and localized responses, and these are the eicosinoids. So the eicosinoids are simply fatty acids that are modified in certain ways to affect localized function. So they're localized, short-acting, effective mediators. And as I've written here, when you're thinking medicine and eicosinoids, it's all about the cyclooxygenase enzymes and how we're going to regulate these. So let's start out with an arthritis patient. An arthritis patient is going to be suffering from inflammation. It's the inflammation that causes the pain. You got a degeneration of the joint. That's going to seem like some sort of wounding response, and so the body's immune system is going to do something to that to try to resolve the problem. So it's going to want to involve an inflammatory response. So the first thing that's going to happen is we are going to have, for example, cytokine secretion by the inflammatory cells. The cytokines are going to be binding to other inflammatory cells that are going to mediate the eicosinoid response. So these cytokines will bind to their receptors on the cell surface, and they are going to induce phospholipase A2 activation. And this activation is going to specifically act on a phospholipid. This phospholipid is a membrane phospholipid, so it's located in the plasma membrane. Now remember the structure of a phospholipid. We have our head group here. We have our glycerol backbone. We have a lipid, a fatty acid. And on the middle carbon, what we have is another fatty acid called arachidonic acid. Now, arachidonic acid is a very, very long chain fatty acid. We cannot synthesize arachidonic acid. So this is coming from our diet, and it's from a plant source. Okay? The arachidonic acid, once it's transported inside the cell, it's conjugated as an acyl linkage to phospholipids and stored in the plasma membrane. Now, once you need to mobilize an immune response, now we're going to want to capitalize on this stored form of arachidonic acid, and this phospholipase A2 is going to cleave the arachidonic acid off of the phospholipid structure. And that is going to release this for the next series of reactions. Now, the arachidonic acid can be processed into multiple different forms. One of the forms it can be formed is a leukotriene. And the leukotrienes are what mediate mostly our asthma attacks. So this is one of our airway mediators that control our inflammatory response in our lungs. This is done by an enzyme that takes arachidonic acid, the enzyme's called lipoxygenase, and it converts that arachidonic into a leukotriene. Now, this is not a major modification. The arachidonic acid is a fatty acid. The leukotriene is also a fatty acid. And so this is a modification of this long fatty acid chain to make a specific molecule that's going to be secreted and act right there in the local environment. Okay, the other response that this is going to have is making a prostaglandin. This is mediated by cyclooxygenase number 2, cyclooxygenase 2 form. This is what's happening in our arthritic patient. So under these conditions, the cytokine is activating phospholipase A, which mobilizes arachidonic acid. What's also being induced is the expression of cyclooxygenase 2. So this gene expression gets turned on. Once the enzyme is present, now we can convert the arachidonic acid into a prostaglandin, and this is going to cause inflammation. Okay? So now, how do we target this pharmacologically in order to help our arthritic patient? What we want is a drug that will block the cyclooxygenase 2 conversion of arachidonic acid to prostaglandins. So we want to block this reaction. If we do that, we eliminate the inflammatory response and we give our arthritic patient some help, some assistance, relief of pain. This is where our non-steroidal anti-inflammatory drugs work. So, aspirin, ibuprofen, naproxen, all of these types of drugs work right here to block cyclooxygenase 2 expression. Now, what's so bad about this? Well, the problem are the NSAIDs. These are considered nonspecific cyclooxygenase inhibitors. So nonspecific means that these drugs will also inhibit the activity of oxygenase 1. And the job of cyclooxygenase 1 is to take arachidonic acid and convert that into a prostaglandin in the gastric lining. Now I'm shortcutting this because there's a whole different classes of prostaglandins that will mediate each one of these different types of inflammatory effects. But the individual nature of these different prostaglandins is really not that critical to your understanding of this concept of the NSAIDs. The fact that cyclooxygenase 1 is in the gastric lining and that's responsible for generating prostaglandin is important because this here facilitates the secretion of bicarb plus mucin. What cells in the gastric gastric lumen, the gastric lining, what cells secrete bicarb and mucin? Foveolar cells, yeah. So if the NSAIDs are so good for arthritic conditions so we can block cyclooxygenase 2, it's very unfortunate that they also block cyclooxygenase 1. Because by blocking this, we prevent the formation of prostaglandin, which is responsible for promoting secretion of bicarb and mucin. If we block the prostaglandin activity here in the gastric lining, what do we have a problem with?
protection.
Loss of protection, yeah. So our gastric protection decreases. Protection against acid. And so this is going to be an increased risk of gastric ulcers. So now, does this make NSAIDs completely bad and unprescribable? No. Because what you need to do is you need to look at your patient's age and susceptibility and risk factors toward gastric ulcers. So if they're someone that's young, that has not had any hyperacidity problems, short-term therapy is really, really good. But being on NSAIDs for a long period of time is going to inhibit this cyclooxygenase 1 and lead to these problems of a GI bleed. So when you hear about NSAIDs promoting GI bleeds, it's by this process right here, the decrease in protection of bicarbonate. Now, how do we fix this? Because we still have this problem with this arthritic patient. There's a lot of them out there. The numbers, the population's growing with the boomers getting older, so there's a way you have to address this.
Give Celebrex because it's COX-2 only.
Celebrex. Celebrex is a COX-2 inhibitor. So this has now been designed to specifically inhibit the cyclooxygenase 2 response, enzyme activity, but it does not inhibit cyclooxygenase 1. Okay? Wow, we've got the miracle drug, right? No, not so much? Wow, if you've got arthritis, isn't this great? I can vouch personally for the effects of this because of watching my dad. He had arthritis in his hips and he walked like this. He took Celebrex, he stood upright, and he started to stride at 90 years old. Wow, that's a freaking miracle drug. So why don't you just give it to everybody that has arthritis? What are the side effects? Remember the side effects of this? Kind of a major side effect, right? Yeah. So what's going on here with Celebrex that is increasing our risk for thrombotic disease? Well, if we look at platelets, platelets' jobs are to aggregate. And so if these aggregate, this leads to our thrombosis. Now, what platelets make so that they can cause this aggregation is that they will convert arachidonic acid into thromboxane. And so the thromboxanes are pro-thrombotic mediators. Now, endothelial cells want to control this activity, and so they will convert arachidonic acid into prostacyclins. And prostacyclins are anti-thrombotic. Okay? Now, these prostacyclins in endothelial cells can be synthesized by COX-2 enzymes. The thromboxane in platelets is synthesized by a cyclooxygenase 1 enzyme. So this is the theory of what's happening with Celebrex inducing thrombosis. If Celebrex is a specific COX-2 inhibitor, we are inhibiting the production of prostacyclins, which are antithrombotic, and that leaves platelets unchecked because we're not inhibiting cyclooxygenase 1, and so thromboxane will be continued expression without the antithrombotic activity of prostacyclin, so this will increase the risk for thrombosis. So what the cyclooxygenase 2 inhibitors are simply doing is tipping the balance. Normally we have prostacyclins and thromboxanes working together to control thrombosis. But if we start taking away the protective function of prostacyclin and allow the thromboxane activity to be unchecked, now we have risk for thrombotic disease. So what do we do with these people that have arthritis? They really, really need some relief because the pain is crippling. So what do you look for as a risk profile in your patients before you decide to prescribe Celebrex? Cardiovascular disease, right? So if your patients have cardiovascular disease risk, you have to weigh that versus relieving the pain of arthritis. And there's a physician judgment. And so that's why that case I had, information on NSAID selection, take a look at that when you get a chance. Because it's up to you to determine, is your patient at too high a risk of thrombotic disease to prescribe them a cyclooxygenase 2 inhibitor? So then you back off and you say, well, okay, let's just try NSAID therapy. Well, is your patient at a risk for a GI bleed? So this is where the balance is in deciding between the NSAID and a COX-2 inhibitor, is looking at your patient profile and then making that judgment call. Am I going to do more harm while relieving these symptoms? Or should I change my medication because my patient has a high risk for thrombotic disease, so COX-2 inhibitors are out, let's try a COX-1 inhibitor and we'll monitor their GI activity. So what's a common way that you could go NSAID therapy for a little bit longer duration than you're comfortable with? What other drug could you administer?
PPI.
PPI, yeah. And so this is becoming rather common. So individuals that have a high cardiovascular risk profile, that the COX-2 inhibitors are just really too risky to go in that direction, go with an NSAID on top of a PPI.